Thanks to everyone for joining us on time. Um, and Claire, I'm happy to start off with the intro, if that's okay. So, first of all, I want to thank all of you for setting aside the time to join us for this particular initiative. I realize it's a significant commitment, and I hope you'll find it rewarding. I'm going to start off with some basic slides about cardio. I know many of you have been involved for some time, so it's been actually 8 years since we were founded. I've been involved pretty much since the beginning. So this is an initiative of the 7 medical schools across Ohio, and the goal is to improve care for cardiovascular disease and related conditions among the Ohio Medicaid population. Of course, not exclusively, but that's the primary target. So we do identify, produce, disseminate best practices through various methods. And many of you have been participating in these before. We had echo clinics. This is a QI initiative. We have podcasts, webinars, etc. Next slide, please, Claire. So special thanks to all the institutions who've supported this, as well as the Government Resource Center, the GRC, the Department of Medicaid as well, and of course our host institution, Case Western. Next slide. So this particular series is the QI project series, and I'll get to what the goals for this particular session are. As you can see, we have a very nice, diverse range of practices from across the state. And we have 6 groups joining us this morning. Very, very different practices overall, all very, very passionate about QI for cardiovascular disease prevention. Next slide. This is our project leadership. So my co-lead is Elise, who is on the call as well. Amanda is our lead QI coach. We do have excellent staff as well, whom I advise you to take advantage of. Whenever I have a question, I ask Andy or Claire because I can never figure anything out. So they're here to help guide us through this process as well. Next slide. Disclosure statements, I don't have any conflicts of interest. I do have a number of roles that outside of cardio that are related, but none of them represent a conflict of interest. And looking at the others involved, there are no conflicts of interest to disclose at this time. Next slide. And for those of you who are interested and or eligible, you can get CME credits as well. You'll get an email from Cloud CME from Case Western for that later on. Next slide.
Both of them. I'm just going to interrupt here real
Yep.
quick. So we've had to change our process a little bit around CME because the vendor at Metro changed. So
Okay.
if you're interested in getting CME, we're asking you to opt in to get the emails. So if Andy doesn't hear from you, either via the chat during this call or an email, you won't get the email to claim CME. That's the only difference.
Thank you, Claire. Okay, next slide. So today's session, the overall objective for me is to kind of get you excited about cardiovascular prevention and quality improvement approaches to cardiovascular disease prevention. So these are our 3 basic goals. One is to identify quality gaps, which to me, even though I've been in this space for a long time, still shock me for various reasons, and we'll talk about those in a second. We'll talk about drivers of the gaps in quality of care. And one framework which has been around for some time used to be Life's Simple 7, Life's Essential 8 from the American Heart Association. So by way of introduction, I'm Goutham Rao. I'm the chair of Family Medicine and Community Health at Case Western and at University Hospitals, and also run our obesity and cardiovascular disease prevention programs at UH, the former chair of the American Heart Association's Obesity Committee, sit on the Cardiometabolic Guideline Committee for the AHA at present. We are in the midst of doing some work to develop our guidelines. I'm also on the Core Quality Measures Committee for CMS that includes cardiovascular quality measures as well. And I'm also on the U.S. Preventive Services Task Force. All this to say that I'm very passionate about preventing heart disease, to say the least. So we're going to talk about gaps in cardiovascular care that, as I said, always surprise me, and hopefully they will inspire you to carry on with your projects. Of course, you've already enrolled, but I think that this is something that some of your colleagues will be fascinated by as well. The overall goal of this initiative is to build QI capacity in cardiovascular prevention. So it's not just us as a group, but it's other providers within your practices and across the state. Next slide. So what do we mean by cardiovascular prevention? First of all, there's a term that's been thrown around for some time. It's called primordial prevention. And this actually deals with preventing even the risk factors from developing. So, we often think about, okay, the classic risks for cardiovascular disease, diabetes, smoking, et cetera, et cetera. But primordial prevention is long before that state. And of course, includes having a healthy diet, moderating alcohol consumption, etc. And there are many, many drivers of poor diet quality. And these in turn lead to cardiovascular disease risk factors. Now, how do we prevent even these risk factors from coming about? There's a number of initiatives that have been tried for a very, very long time. The most effective, basically, are policy interventions. As many of you know Jackson Wright, who was part of our cardiovascular series, who pointed out that subtle changes in the amount of salt in the foods in United Kingdom have led to a lower incidence of stroke. They lower it by 0.1% every year or something like that, so nobody notices. But if you go over to the UK and have a bag of chips or crisps, as they call them, you might notice a difference right away. And that's the sort of thing. So that's a policy initiative that people have supported. Another innovative policy they have there is that if you were born after a certain year, you cannot purchase cigarettes. And I don't remember what the year is. I think it's 2004 or 2005. Certainly doesn't apply to me, but if you were born after that date, no matter how old you get, you could be 80 years old, you're not buying cigarettes. And the idea is it will phase out the use of tobacco entirely. So those kinds of progressive policies may have an impact. Now, these all lead to cardiovascular disease risk factors. So primary prevention then is preventing cardiovascular disease. So this includes, of course, statin intervention, statins, etc. In order to in order to treat dyslipidemias. And secondary prevention, these are folks that have disease, and you don't want them to have additional events, etc. Next slide. So one framework for thinking about cardiovascular disease prevention, and I think that I've always found these frameworks really, really helpful. And the analogy I've used for a long time is that a very unhealthy gentleman who's in his late 60s, who has heart disease. Um, um, I'm sorry, Carolyn. I'm British. Okay, thank you, Carolyn. Um, and who has heart disease, who and diabetes, and has an unhealthy diet and smokes, was leaving my clinic one day and asked if he should take a vitamin every day for his health. And of course, my response to that is you can take a vitamin, but you've got at least 8 other things to work on, which I think are really, really important. So the framework the American Heart Association developed many years ago was Life's Essential Eight. And um, they are healthy sleep, healthy diet, physical activity. I'm just going around in the circle here. Normal blood glucose, normal weight, lipids, blood pressure, and not smoking. So, um, a nice way of implementing this is to say, well, if you want to improve your overall health, and of course, cardiovascular disease is not everything, but it's a big part of what we do in primary care. Think about where you stand with some of these interventions, and then we can move on from there. We can discuss the specifics of each one later on. But I've always found that framework to be helpful. I encourage you to go to the American Heart Association website and at least there's tons of educational materials around this particular framework. Next slide. Here's the problem. Um, there have been dramatic improvements in cardiovascular mortality over the past 50 to 60 years. Some of the biggest bangs for the buck came from cigarette smoking. Cigarette smoking used to be 45% of the population. And I know here in Ohio, we are disproportionately high at around, I think, 18 to 20%. but that's still a dramatic drop from where we were in the early 1970s. Of course, agents such as beta blockers, thrombolytic agents, cardiovascular procedures had a lot of improvement, but it's not dropping anymore. It's been pretty static for the last 10 years. This is not necessarily related to COVID. If you take COVID out of the equation, cardiovascular mortality is no longer falling. And there must be some drivers of this that we'll talk about in a moment. Next slide. Rural areas, it's actually going up. We're not sure what is going on. And of course, many of you practice in rural communities across Ohio, but age-adjusted mortality is actually increasing. COVID may have something to do with it. Increases in obesity, stress, access to care, etc., were affected. However, even taking that out, cardiovascular mortality is rising. Next slide. Racial and ethnic disparities, as you can see, overall age-adjusted mortality has dropped significantly over that 15-year period from 2000 to 2015. And the actual relative order of disparities is significant. So African Americans, non-Hispanic Black Americans had very high age-adjusted mortality, and there's been tremendous progress here that's taken place over the last 15 years, there's no doubt about it. Less significant progress among white Americans. I think the encouraging thing is among Latinx folks, quite a substantial drop. And of course, among Asian Pacific Islanders, quite a substantial drop as well. But these disparities have been around for a long time. There have been some improvements. Again, you can see this sort of flattening out here around 2013, 2014. That hasn't changed. Next slide. So why are we flattening out? What else can we do? Um, you think about many of you are in primary care. I struggle with this too. I really need you to quit smoking. That's the best thing you can do for your health. Here's the Ohio quit line, 1-800-QUIT now. Here's my prescription for you. Prescribe nicotine lozenges, gums, patches, whatever they want. Come back and see me in 3 months. Have you quit? No. No, they haven't. So it's tough, isn't it, to get to that last mile? But there are things we can do, and that's what this whole initiative is about. So why do we fail? There are large missed opportunities at every step in the prevention and treatment of cardiovascular disease. Failure to make risk factor modifications. Now, this is largely patient-driven, such as smoking. And of course, that can reduce the odds of cardiovascular disease by 80%. Failure to elicit and follow people's goals and needs. Higher patient activation leads to better healthcare experiences. Patient activation is a relatively simple intervention. And I know I've said this hundreds of times. I do research in adolescent hypertension. The most effective intervention I've ever developed is a sign in a waiting room that says, ask your doctor about your child's blood pressure. Some parents come in and ask. Many ignore the sign. Some doctors ignore the question. Some don't do much about it. But such a simple intervention actually activates the patient to take the problem seriously. Why does it have to be childhood hypertension? It could be ask your doctor about help and get quitting smoking, etc. There are many ways to activate patients. Failure to diagnose is of course, we have a AHRQ funded diagnostic center that I'm the PI of at University Hospitals. And improving diagnosis is a big problem, especially undiagnosed hypertension, which is always surprising as to why it happens. Undiagnosed hyperlipidemia, these are big problems. Failure to use proven first-line treatments, failure to use advanced treatments such as PCSK9 inhibitors, and of course, failure to provide supportive care and for patients, for example, with heart failure. This is kind of the last step. We're going to focus on some of these other ones as missed opportunities to begin with. Next slide. So what is the biggest risk factor is blood pressure. And there's many reasons why we are ineffective in controlling blood pressure, hypertension. Um, Clinical inertia is a significant one. I see a patient whose blood pressure is modestly high. The patient is there for an ankle sprain or something completely different. I address the problem. I may say to the patient, your blood pressure is high, go back and see your regular PCP or come back and see me. They don't do that, or they miss the appointment. The regular PCP says, Dr. Rao wasn't too worried about your blood pressure 3 months ago. Let's watch it for another 3 months. And this goes on and on and on. Um, of course, obesity, physical inactivity, smoking. It's always interesting to me that some of the things that we are very, very focused upon, polyunsaturated fatty acids, low intake of fruits and vegetables, are relatively minor in terms of their overall impact. In fact, it's almost like if everybody quit smoking today, in 20 to 30 years, COPD would be a relatively rare condition. We would still have occupational lung disease, alpha-1 antitrypsin deficiency driving it. But it would be like, oh, wow, we'd be, teaching our med students and say, look, this patient has emphysema. Well, that's something I haven't seen since early on in my career. But if we eliminated hypertension from across the country, imagine how few people would have strokes and cardiovascular disease, broadly speaking. And it's saying that if you alcohol use, of course, this is kind of spurious in a way. Um, but it deals with moderate drinking and its benefits overall. Next slide. So here is the issue. Let's take a look at a very high risk population, and those are folks who have type 2 diabetes and have established heart disease. This is a pretty vulnerable population. Okay, we're not talking about primordial prevention or treatment of risk factors. These are people who have the illness itself. And there are three treatments, among many others, of course, that are recommended for those. That they should be on a high intensity statin. This is atorvastatin, 60, 80 milligrams a day, for example, an ACE inhibitor or an angiotensin receptor blocker, right? And more recently, since about 2020, 2021, an SGLT2 inhibitor or a GLP-1 receptor agonist. Um, 37% are not on any of these. That's astonishing to me. So these are people who are engaged in care who come in to see you who are not on a statin and they've had a high intensity statin rather, and who have actually have heart disease. It's astonishing. About 40% are only on one. All three treatments, 2.7%. That's incredible when you think about it. We'll talk about why in a moment, but this is the huge gap that I'm hoping we can address. Now, it doesn't have to be with these specific interventions, nor does it have to be with this population, which is very high risk. It could just be with folks that have hypertension. Imagine the number that have uncontrolled hypertension. Imagine the number who have type 2 diabetes, who are not on an SGLT2 inhibitor, etc. So next slide. Why are we doing so poorly? Well, let's not, we should never blame our patients because they have incredible challenges, healthcare beliefs, ability to follow recommendations, literacy issues, etc. But patient factors, including knowledge, are significant barriers for us achieving higher quality care. You've all heard things such as, I only take the water pill when I feel like my blood pressure is up. I can't remember how many times I've heard this sort of thing. General health literacy, I've worked on many, many times. When I was at the University of Chicago, looking at the south side of Chicago, 80% of the patients who come to some of the underserved clinics there, when given a bus schedule and told what time it is now, and told what time the bus is coming, cannot determine how many minutes they would have to wait for the bus. And therefore, they don't get to the bus stop. They don't walk to the bus stop in a sufficient amount of time and miss their appointment. This is a more recent example. Many of you know that the GLP-1s come in pen needles that you turn, etc. I was telling this gentleman and his wife, you need to turn it counterclockwise. They had no idea what that meant. And here I am using this language, having been a family physician for almost 30 years, thinking that this is something that everybody ought to understand. No idea counterclockwise what that means clockwise. They may have heard those terms before, but operationalizing them was not something they were able to do. So health literacy is a big one. Physician knowledge is a problem. So it's hard to stay up to date with all the guidelines. And, for example, prescribing SGLT2 inhibitors, still a little unfamiliar to people. Engagement is tough when you see 25 to 30 people a day. Is this a priority? And then, cardiovascular risk prevention and treatment is one aspect of care. There's so many others that we have to do. And I talked to you about clinical inertia. It's sometimes easier to defer care for lots of reasons. Clinical inertia got a lot of attention. Um, it's been redefined. It's failure to act, assuming you believe in the evidence-based treatment, assuming you have time to implement it, and there's a solution that's available. So it's not just, so clinical inertia doesn't apply to everything. If you're seeing a lot of people per day and you want to talk about smoking cessation, and this patient's going to be at least 10 to 15 minutes to discuss the issue with them, set a quit date, et cetera, and you don't have time to do it, that's not clinical inertia. That's the system not providing you with the opportunity. System factors have a lot to do with it, cost and access. Of course, these are issues as well. Next slide. Now, the good news is, now it's a pretty depressing picture I've painted so far, but the good news is that there are models that work. This is something I know many of you heard of, Million Hearts. Actually, I think it's to prevent a million cardiovascular events by next year. 2025, 2026 is the year that they're looking at. So this is the Million Hearts program, and you can certainly go to their website. It's run by the CDC, has a number of educational QI type programs available. We certainly have been implementing this here at university hospitals in our network, etc. But I think the important thing here is that the potential to improve quality of care exists. So it's not a hopeless endeavor, despite the patient challenges, despite the time challenges, etc. Next slide. And this also applies to diabetes care. This is a Cochrane review from 2023, so not that long ago. Large numbers of QI strategies for diabetes care, and they do have a tremendous impact on outcomes, not just morbidity and mortality, but on quality of life among patients with type 2 diabetes. Next slide. So I want to leave you with a few basic messages. First of all, that cardiovascular morbidity and mortality is no longer falling, and that applies to Ohio as it does to other parts of the country. There are basic fundamental gaps in quality of cardiovascular care. Some of them are glaringly shocking to me, and some of them are difficult to address and more subtle. The drivers of those gaps are not our individual desire to provide the highest quality of care. I sincerely believe we all want to do that. Nor is it that patients are indifferent, but there is a middle ground as well that deals with health literacy, system factors, tools to implement quality improvement, which we will discuss throughout this particular series, etc. And the final message I want to leave you with is the potential to improve exists because it's been shown to be true. The first crucial step for all of you, I think, is when you are with an individual patient, just do the ASCVD risk estimator tool. This or Life Simple 7. These are both ACC and AHA tools that are widely available. Show your patient what their 10-year risk of having a cardiovascular event is. It will be activating for them, it'll be informative for you, and it'll give you some targets that you can intervene for moving forward. Okay, next slide. Thank you so much, everyone. We can take, I've almost used up my half hour, Claire, so we can take some questions and then move on. Let's see me see what's in the chat. Carolyn, I find it fascinating that your U.S. friends find there's not enough salt in in the foods.
Yeah, I'm
I,
glad you said fascinating. They say I can't cook, but it's what your palate gets used to.
it is, yes. And I do travel to Britain quite often, and I notice almost immediately that there's a difference.
Also, a difference in portion size.
Yes.
I've noticed I was in the UK in December, and
Mhm.
I noticed on lots of the processed foods that they have labels on there, just red, yellow, green. And the red is indicating this is not particularly good for you. This
Mhm.
has a lot of salt and preservatives in it. So people tend to buy their meals based on, that red, yellow, green. Such a simple strategy.
It
We all
is.
know red means stop.
It is. And the EU has adopted that particular convention as well. I think that right now we're in a, I have to be careful about what I say, of course, a precarious political time here in the United States. So I can tell you from the federal level, there's little appetite for those sorts of public health measures. There was, and this is an entire aside, so in 2014, and you can Google this, I testified in Congress on behalf of the president at the time and his wife, who was very interested in these issues. And we almost got that over the finish line. And the initiative was to regulate competitive foods in schools to make sure they met USDA standards. But I can tell you, I think we're a little bit far away from this. And unfortunately, Europe, the United Kingdom, and other countries are moving very quickly in a positive direction. But that doesn't mean we can't be, as individuals, very proactive in helping our own patients and our state as well. Any questions? Steve Swain, any comments on Repatha getting the recent need for primary prevention? Yeah. Thanks, Steve. Um, it's one thing for it to have the indication. Steve, are you on actually on camera or I can't find.
I'm
Hi, Steve.
driving,
Yeah.
so I'm mute. So I've had my camera off.
Oh, no, no problem. I just wanted to make sure that I don't know, first of all, if you've had a lot of success with coverage for Repatha, and secondly, how what the response has been among patients. And I think this has to be incorporated into guidelines more robustly before we can see that. So for the purpose of this QI initiative, are we going to talk about PCSK9s or are we going to limit our discussion to high intensity statins? That's really a question of, your individual projects, et cetera. But I don't have any more information about that than you might have. So,
Thank you.
okay. Anyone else have any comments about um, newer lipid lowering medications and how they might fit into an overall QI strategy besides filling out the prior auths?
I was just going to say that the prior auths and the costs and the formularies,
Hmm.
all of the things we all know.
Yeah.
As
And so I mean, I think Steve raised an important point. What is the purpose of this particular series? It's to build QI capacity and it's to go after the low-hanging fruit. So, and Elise and I have talked about this. We'll begin each session with a very, very brief clinical review, but I do not want to get into the indications for PCSK9 inhibitors, SGLT2 inhibitors, their benefits, the evidence surrounding them. That's not the purpose here. Hey, can we get this patient to take a statin? That it's more fundamental than those things. Okay, any additional questions? Okay, if not, I think we'll go back to I'm sorry, we're going back to our case study. So, and Claire, was there any additional comment before we go into this?
Nope.
Okay, thank you. So we're going to spend a little bit of time. This will be part of the overall format for our sessions, and they will hopefully be closely matched to some of your projects. It's very difficult for us to match the clinical content or the QI content of every session to what you specifically have proposed. Nevertheless, I think these will be applicable. There'll be principles applicable to the uh, entire set of projects that we have. So here's our case discussion. These are all fictional. And what we're going to do is kind of brainstorm around how we would address these issues. So first of all, let's talk about the practice itself. It's Mount Orion Family Medicine. It doesn't really exist, of course, caters to a rural population with a high prevalence of obesity, which is not unusual. The target for this particular project that is a hypothetical is improved identification, counseling, and management of obesity. Next slide.
That's all the slide.
Oh, I'm sorry. I thought I had
Okay.
another. Okay. All right. So I think the brainstorming is, let's say that we have a substantial portion of the adults in this practice whose obesity is undiagnosed, meaning there's no recording of it in the chart, nor has there ever been a discussion between the patient and their physician. There's not been any counseling and there's been no management. These are all quality improvement measures that are approved by CMS, as many of you know. This is a U.S. Preventive Services Task Force priority as well. What I think we would like to do is have your ideas, first of all, about how you would improve diagnosis of obesity. Let's say it's something astronomical. 40% of the adults in this particular practice have obesity with no diagnosis. How would you change that? And let's say you have 3 other providers in your practice. Any thoughts on how you get started?
So with obesity, good morning. My name is Jim. I'm from East Liverpool City Hospital, and Dr. Swain and Dr. Grossman have been my mentors in this residency program. So in the context of obesity, obesity is, of course, defined by the BMI of a certain individual, so that the normal BMI is 19 to 25. So anything more than that is, we all know the parameters already, the classification. So obesity, we start from there. We start by knowing their demographics, and then now the higher you go with the higher the range, the higher you go with obesity, comes with, of course, identifying the different health risk factors surrounding that obesity. So, like Dr. Rao was saying in his lecture, that it's not just one parameter that we're going to be concentrating on in the context of healthcare. We're going to be identifying that, does this patient exercise, does this patient smoke, and does this patient take medications consistently? So during the clinical visits, the role of family practitioners is to identify those independent variables, if I may say, in order to address a particular target in reducing the ASCVD risk. So that's how I would approach this one.
Looks like Goutham froze. Lisa,
Hello.
I don't know, and Claire, how we want to handle that. Maybe we can.
Okay. What
Very good.
Did
It wasn't you, Jim. It was,
yeah.
but
Did were
it
were you
looks like he signed off. We'll wait a second for him to come back.
okay?
I wonder if while we wait, anybody else wants to share how they might work on this identification, counseling, and management of obesity in this practice.
Hi, this is Steve Grossman from East Liverpool. I would also think about perhaps some kind of a screening situation, whether you're setting up at the mall or setting up at some kind of an outdoor event where people are coming through a fair or something, and just do free blood pressure screening, record that information, giving that information to the patient, encouraging them to take that to their doctor, and then perhaps engaging in a conversation that may look at their multiple risk factors and go forward with some kind of a treatment plan.
Hi, everyone. I'm sorry. I somehow got disconnected and mysteriously, and I'm not sure what's going on here. I did catch some of Jim's discourse, which was very helpful. Steve, could you repeat what you had just said, if you don't mind?
Sure. I was talking about doing a community screen of some sort, setting up at a mall, setting up at some kind of a, an outdoor fair where you do free blood pressure or free weight screening, and giving that information to the patient and encouraging them to take that information to their doctor, or perhaps even sending it to their doctor so that the doctor could then initiate a follow-up visit and risk factors could be evaluated.
Yeah, I think both of those ideas are excellent. So, there's a long time ago, someone told me that community screenings don't necessarily work. But if you're in a small rural community and you print out something that says, here's your overall heart risk, it can be activating for a patient. Of course, most people who have obesity are fully aware that they have the problem. Most people smoke. Of course, they know they smoke and they know it's unhealthy. But giving them an overall picture is really helpful as well. I think that I wanted to ask you guys the question, why do you think such a small proportion of patients in this practice have the diagnosis of obesity? Why is it underdiagnosed? Does anyone have any thoughts about that?
This is Arpita. I think it's more to do with the patient inertia and the provider inertia, like labeling a patient as obesity or obese, unless the patient brings up the concern, is something like, it's to do with the patient-provider relationship to bring it in a proper and a communicable way, rather than like, the in front of the staff or something like, it's respecting their feelings.
Yeah, excellent. Arpita, so only about 10% of patients have ever discussed their weight with their physician. These are people with obesity who discuss their weight with their physician. The reasons are twofold, and it all comes down to a skills issue. And this is something I think that I know people have different QI initiatives, but is right for a QI initiative. I was on the National Academy of Medicine's committee on obesity years ago, and we concluded that there was a way to do this, and the language is very critical. You say to the patient, I am concerned about your weight. It puts you at risk for a heart disease, hypertension, just a list of things, obstructive sleep apnea. Is this something that concerns you as well? Is this something you'd like to work on together? I've used that now for 25 years. Not a single patient has ever said, no, I'm not concerned, don't want to work on it with you. Now, there may be some underlying ambivalence. They may not truly be interested, but the method is called opening the door, and it opens the discussion about weight in a respectful way. if we could do this across a practice, you would see the number of diagnoses and the amount of help increase dramatically. But as Arpita said, it's both patient driven. I don't want to raise the issue. I'm embarrassed, or it's too sensitive for me. It's also physician driven in the sense that I don't want to raise it with my patient for fear of offending them as well. But there is a way to do it. And then what other drivers do you think there are of poor diagnosis and lack of management?
Availability of resources, especially
Yeah.
like weight management or the options on the insurance coverage and care coordinators, depending on like how easy it's through the system.
Mm-hmm. Absolutely. So it's actually detrimental if you say, I'm concerned about your weight, I'm going to help you, I'm here for you, and then you have very little to offer. This is a major barrier. In other words, there's no time for you to provide accurate counseling. You may not have the expertise. As Arpita said, there's no resources in the community. These are significant barriers that can also be addressed by linking patients, for example, to different resources if and where they exist. Now, there are resources available for many of our Medicaid recipients, but connecting them is an important skill that hopefully we can address through quality improvement efforts as well. So if you were to design a QI initiative to address, let's just say, increased diagnosis and counseling related to obesity, and you have 3 additional providers in your practice, how might you get started with it?
My thoughts about that about obesity in terms of addressing that particular concern
Mm-hmm.
is to tie it, pair it with a certain risk factor, because out there in the real world, people, when they encounter the term, oh, obesity or overweight, almost always their reaction will be, do I need to do exercise and diet, which is already part of the 8 parameters that Dr. Rao has mentioned in his slides. But then there is more to it, because with obesity, the higher your number is, it tends to get tied up with a certain metabolic syndrome. Again, that was mentioned earlier, so that in the clinical practice, if the patient is already aware about, do I exercise, do I diet, if they already know that in the clinic, we as providers, we will identify the certain risk associated with it, be it high cholesterol or smoking or hypertension. We will tie those risk factors with obesity and then talk to them about, hey, your risk for stroke increases because you smoke at the same time, you have high blood pressure at the
Mm-hmm.
same time. And then once we identify those risk factors, again, those are the independent variables that we attach so that we work on lowering their ASCVD. That's how I would approach it.
Yeah, and I think that's an important approach, Jim. The other thing I would say is that if someone has obesity and they don't have those risk factors at present, you can also let them know that you are at high risk for developing high cholesterol and type 2 diabetes, regardless of whether they have those or not. So, but that is a good approach. Amber, you were about to say something. I'm sorry, go ahead.
Yes, so usually, can you hear me?
Yes.
I would try to approach that with like coming up with a process, like with all providers, we're using the same language,
Mm-hmm.
and approaching risk identifications and, like making sure we're all saying the same thing when we're talking about
Exactly.
diagnosing. but also just kind of having a spiel that we're all using this. I can't even lost for words today, but that would be my first process in the office with providers and with staff.
Yes. Excellent. Yeah, and actually we've done that. So the person weighing the patient is typically not the provider, right? It's an MA, and they'll say, okay, and it's fine for an MA to say to a patient, I'm worried about your weight. It's going to put you at risk for some of these conditions. Go and talk to Amber about it when you go into your encounter, go and talk to somebody else. And of course, if they repeat the same message, yes, I am worried about it, and is this something we can work on? It opens the door in a way and sends a powerful message and empowers the patient with some valuable information as well. Okay, what else would you do once? What other aspects of your QI program would be helpful if you beyond training and communication? Well, how many of you have an electronic health record that automatically flags BMI and obesity? Yeah, so if you want to improve diagnosis, certainly that's available to you. I think that if you don't address it in the encounter, it's problematic. So, in other words, a patient has a BMI over 30, which is, of course, not a high BMI for many of my patients. And on the discharge, the after visit summary, obesity is automatically printed out as a problem. That's probably not the best approach. It's something you need to discuss in advance. But are there any other tools that we could use, do you think, that would improve diagnosis and counseling?
I would also like to do food diaries or just like food logs with my patients.
Mm-hmm.
Especially like if they also have other factors, risk factors like elevated blood pressures or, anything else. Because a lot of patients will say, well, I don't know what to eat. I don't know how to eat. I don't know
Mm-hmm.
how to exercise. So, we try to start with something like give me a week's worth of your food logs, and then we can talk about how you can add this or subtract that, or,
Mm-hmm.
different little things like that. Also using our allied so everyone, so nutrition, um, different programs that are in the community that could be supportive for education.
Right. Yeah, there's a lot of ways to provide support to the patients, and I think that you can incorporate relatively simple tools into a clinical encounter that has nothing to do with obesity. When you say, okay, yeah, I understand you're here for your routine gynecological visit. By the way, I'm also concerned about your weight. Here's a four-step, well, we can talk about this later in the QI series, but here's four things I'd like you to do between now and your next visit. And how does that strike you? Which ones are going to be easiest? Which ones would you like to focus on, etc. So I think giving our providers tools with which they can provide counseling in an efficient way is critically important. Um, the diagnosis is no mystery. I mean, once you have had that discussion, you're likely to have coded obesity in the chart, and hopefully that's something other providers will address in the future as well. Okay, any other thoughts on how we might improve quality of care for obesity? Jeremy, you look like you're about to say something.
No, I'm just like leaning to.
I
Steve,
know
go
that
ahead. Yeah, go ahead.
I've seen things in communities like walk with a doc and things like that, where you could, one, promote exercise with your
Mm-hmm.
patients, and two, have some like time to speak with them about obesity and the
Mm-hmm.
importance of walking or what have you. And I know that's not common, but I've seen it in our community multiple times with some doctors that have been promoting that walk with a doc type uh, interaction with the patient because it gives them a little bit different interaction out of the office and a little bit different environment. So that could be a way to help promote getting people activated and interested in helping themselves with their obesity and their weight.
Yeah, I think raising awareness is a useful tool. Arpita, go ahead.
Having patients actually talk to us about their root cause, or like, what's actually hindering them from having like workout through their goals. Like if someone is having knee arthritis or severe sleep apnea, they can't exercise. So addressing the root cause and like trying to help them, only like, fixing that before saying like, okay, go exercise or like do things that might help the patient understand that we really care for them. And like, coordinating the care is something that I think is the key role.
Yeah, I think that understanding barriers is important. Self-efficacy is important as well. In our medical obesity treatment program, 90% of the patients are women. Not that 90% of all people with obesity are women, it's just they're the ones who want it. And 80% of them are African American women. And sometimes they see obesity as inevitable. And so sometimes I show them a picture of a secretarial academy from Mississippi in 1960, which is all African American women graduates. And I ask them to take a look at the picture. And I say, oh, and they almost immediately say, well, there weren't too many women who were overweight then. I said, no, don't say there weren't too many. There were none. There was zero. And they're like, what? I go, there was zero. And this is in 1960. And they're like, oh, so you understand now it's not inevitable. Okay, so there is something that has changed in our society that tends to provide a little bit of activation and inspiration for them as well. So I think self-efficacy, understanding barriers, Arpita, is really important. But to saying, okay, I understand you've got some barriers. You know, you've got a busy family life, or you've got this or that, or something else going on. What is it that you can accomplish? All these, I think, relate to the patient side and how we address patients with obesity. But there's also, of course, the provider training that you mentioned as well. Okay. Any additional thoughts? And I think we'll have to wrap things up. Go
I
ahead.
just want to point out that we do have a practice actually on this project that's doing something innovative. They're opening a food pantry.
Mhm.
And then if they have a patient that screens for like a food insecurity, they're bringing them in to educate them around healthy
Mhm.
food choices and then giving them an actual basket of healthy food. So I find that
Yes.
to be like an innovative way to incorporate some of this work.
Great. Thank you, Amanda. Okay, we just have a few minutes left. Are there any final thoughts before I turn things back to Claire? And I actually, I should have done this at the house. I want to give Elise a moment to introduce herself as well. If you, I know you've probably a lot of you have met her, but Elise, do you want to maybe start off?
Sure. Good morning, everyone. Thanks for joining. I'm Elise Karen. I think I met all of you at our kickoff, but I'm co-leading this with Goutham. I'm over at Metro in the Population Health and Equity Research Institute. And my background is quality improvement, implementation science, and workforce development. I'm excited to work with all of you.
Thanks, Elise. And Claire, back to you.
Or so in our last couple minutes here, we were hoping that we could have a representative from each practice kind of give a quick update. Amanda already did one for you of kind of what your project that you're working on. So we can get an idea of what everyone's working on. As we all know, we're all doing QI projects in your individual clinics. So to make it easier, if it's okay, I'm just going to call on, I have the kind of my main point of contact listed here, but just a couple sentences would be great if Steve or Jim, whoever wants to kind of take it for East Liverpool, if you want to share what your guys' project idea is.
Okay, yeah, so I can do that. So our QI project here in East Liverpool City Hospital, again, I am with Dr. Swain and Dr. Grossman. So the title will be Hitting a Target Goal of LDL Less Than 70 for Patients with ASCVD Risk Factors Using and Adjusting Statin, Ezetimibe, Bempedoic Acid, and PCSK9 Inhibitors.
Great. Thank you, Jim.
Yeah.
Erie County, I saw Chesney, are you on still?
Yes, I am. Sorry, is my volume working?
Yep.
Yes,
We can hear
we
you.
can hear you.
Sometimes it gives me a little bit of issues. So for Erie County, what we decided to do was to look at our A1C measures. Our A1C is above 9 or untested, and get those below, get them below 9. So at our health center, we've been struggling with our A1C measure. And we have a lot of patients that are either above 9 or for some reason are untested, which means that we haven't gotten an A1C on them within the last 12 months. So we worked with Amanda on creating like a smart aim for this. And our goal is to get our percentage right now is 23.9%. And we're really trying to exacerbate this goal and get it down to 18% by the end of this quality improvement period. So just been really working on that, and we're going to do a random sample for our monthly data, but we're going to do the same patients to track them along the QI project.
Great, thank you. I don't think we have Fisher-Titus on, but this is also an opportunity for iPhone to unmute and let us know who you are, so we can mark you off for your attendance, please. Thank you. So Healthcare Connection, William.
Yeah, we are also working with patients with high blood pressures, anything above 140 over 980. So, can you hear me, please? Can you hear me?
Yep.
Oh,
Go ahead, William. Yeah.
we are working with patients with high blood pressures, anyone or patients with blood pressures more than 140 over 80. So our goal is to help them follow those patients and help them stabilize their blood pressure.
Great. And then Arpitha at Metro.
Our project is to see patients with ASCVD risk over 10% to decrease who are not on statins to improve. Sorry, I'll redo it. So the project is about like decreasing the patients who has higher risk based on their ASCVD risk over 10% to initiate statin, and also like decrease the scores from 30% to 20% in next 1 year.
Thank you, Arpita.
And then Amber.
Good morning. So with the Village of Healing, our project is to reduce our patients with identify our patients with high blood pressure and get their blood pressures lower. We're going to be following them. Our goal is to increase their follow-up, their attendance with follow-up appointments, but also making sure we are focused on a good process for getting blood pressures in office. So far, we've been very successful with just implementing a standard process and getting patients scheduled before they leave their appointment.
All right, thank you. And thank you, Emmanuel. Mystery iPhone solved. So just a quick wrap up. Thank you all for attending our first Echo Clinic. We're excited to get these underway. As a reminder, these are the first Thursday of every month from 8 to 9 on Zoom. We did switch July and January for holidays, but otherwise they're the first Thursday. How we do this is we send a very quick, brief kind of follow-up survey. We do it automatically through our RedCap system. So you've all been put into the system and you should have an email sitting in your inbox. We do appreciate if you could fill that out. That just gives us feedback on each clinic, and we will do that every time we have these monthly clinics. The general cardio email is there, but also feel free to reach out to either Andy or myself with any questions or concerns you have around the ECHO project. And then just another reminder to submit your de-identified monthly practice data. I sent everyone who we do not have data for emails yesterday. If you have questions on that, reach out, let me know. The baseline data is due May 7th, and then your next round, April, May, and June, all separate months, but those are due June 6th. If you ever have any questions, please let me know, and please be sure you're submitting the de-identified version. That is it.
All
Thank
right.
you all very much.
Thank you, everyone, for joining us. Thank you, Claire, and we will see you all soon.